Good morning all. My topic is morbid obesity and anesthesia under guidance of Dr. Jyoti Kulkarni and Dr. Rashmi Bengali Madam. Obesity in India, it is the second only cause to smoking as a preventable cause of death. Major cause of morbidity and mortality resulting in enormous impact on the healthcare expenditure. How we define obesity? Obesity is defined as abnormally high amount of adipose tissue compared with the lean muscle mass, 20% or more over the ideal body weight. In terms of waist circumference, we find as it is more than 88 centimeter in women and 102 centimeter in men. A waist to height ratio more than 0.5 defines central obesity. WHO classified obesity in terms of BMI. So more than 30 kg per meter square is termed as obese class 1, 2 and 3 as shown in this slide. And more than 50 is termed as super obese. So coming to our case, a 32 years morbidly obese female with total body weight of 166 kg and height of 158 centimeter. Her BMI was 66.5 kg per meter square. She came to the casualty and presented with history of pain in abdomen since 4 days and complaints of vomiting since 1 day. She was a known case of hypothyroidism since 4 years on tablet Eltroxin 100 mg OD. Then further history revealed over the last 3 to 4 years of witness snoring. She was comfortable in lateral position while sleeping and awakening from the sleep sometimes during the night. We evaluated her effort tolerance also. She could take care of herself, walk around the house, does light household work also. And surprisingly, she could climb 1 flight of stairs without obvious discomfort. So her med score was 4 to 6. When we went to ward for preoperative assessment, she was lying down in the lateral position with the 2 pillows below her, beneath her shoulder and head. We make her sit and did the airway examination. She had this large tongue, enlarged soft palate, short and thick neck. Her nostrils were patent. There was large hump over the nape of the neck. Her incisor gap was 3 centimeter. Malam patti class 3. Neck circumference was 46 centimeter. Upper lip bite test was grade 2. And thyromental distance was 9.5 centimeter. These are the predictors of difficult airway. Then waist to hip ratio was quite significant, 1.33. We did her spine examination also, so there was difficulty in palpation of bony landmarks. We did her bedside PFT also. The respiratory rate was 20 to 22 per minute. Her bedside SpO2 was 95%. Breath holding time was quite good, 25 seconds for her weight. Then cough test was adequate. All investigations was quite normal. Her CT scan suggestive of strangulated supraumbilical hernia with omental infarction, and her defect was 4.3 into 3.3 centimeters. So what equipment we have arranged for this case? 2 OT tables, high weight capacity. We joined side by side to bear her weight. Then for RAM, as you can show in this picture. Then for RAM position, we arranged bolster pillows for her. Then longer spinal needle was arranged. Appropriate size BP cuff, as you can show in this picture. We have to arrange for that also. Extra human resources for her to shift from OT to ICU or ward. We have to arrange for that. Difficult airway cart was kept ready. Suitable shifting trolley for her. All pressure points padded to avoid the pressure source or nerve injury, as they are more prone for fracture. This adequate strapping was done, prevent fall her from the OT table. And for DVT prophylaxis, we have to arrange for this appropriate size compression stockings for her. You can see in this picture, she was encouraged to walk from pre-operative area to the OT table, eventually climb the OT table with support. Coming to anesthesia management, first we planned for general anesthesia plus regional anesthesia for this patient, as it was supraumbilical hernia. After taking patient on the OT table, all monitors were attached. Vitally, she was stable. IV line was quite difficult. We secured IV line on the dorsum of hand with a 20 gauge cannula. Aspiration prophylaxis was given. Sitting position with all aseptic precautions. We tried epidural catheter placement at T12 and L1 intervertebral space with 18 gauge to his needle. And we confirmed the epidural space with loss of resistance technique at 7 centimeter. But after placing the catheter, we observed the frank blood in the catheter. So we replaced the catheter, and again the same thing was happened. So again we tried at L1, L2 intervertebral space also. The same thing happened. This was because of maybe because of epidural engorgement of veins in the epidural space. To avoid unnecessary complications, we abandoned this procedure and we give intrathecal 50 mg fentanyl, as already sitting position was given, single prick we got this free flow of CSF, and 50 mg intrathecal fentanyl was given to her. After this procedure, we given her a ramp position to ease the intubation. RT aspiration was done. Patient pre-oxygenated with 100% O2. We pre-medicated her with midazolam 1 mg and fentanyl of 50 mg. Then we started induction with propofol in graded doses. So she required total of 150 mg of propofol. So ventilation check, patient could be ventilated. So we gave muscle relaxant, succinylcholine 2 mg per kg. So total 120 mg was given. Under direct laryngoscopic wave, Cormac-Leon grain was too big, so we have to apply little external laryngeal pressure. We could intubate her with ET tube of 7. Air entry was checked, tube fixed and secured, and we maintain her on O2 air, sevoflurane, and intermittent ultrafluid. Coming to our intra ventilation strategies, we gave tidal volume of 500 ml, titrate rate of 60 was maintained to maintain ET suit of 35 to 40 millimeter of mercury, and PEEP was added 6 centimeter of water on control volume ventilation. So we monitor her with ECG, SpO2, NIBP, EtCO2, and urine output. So for intra pain management, already intrathecal fentanyl was given, so it was quite effective. We didn't see any surgical response. Again, this pre-medicated with fentanyl 50 mg. Intraoperatively, we give paracetamol 1 gram. We planned her for active ventilation overnight. So before shifting, we gave pentazocine 30 mg. We electively ventilate overnight her with same ventilating strategies, and we added a drip of muscle relaxant, vecuronium, and midazolam. Round the clock, we gave paracetamol 6 hourly and diclofenac 8 hourly. After 5 to 6 hours, we observed this rise in BP consecutive 3 to 4 readings. So we increased our muscle relaxant and sedation drip, but it couldn't help. So we gave Labet 100 mg in graded doses for her. So it was settled down for 1 or 2 hours. Then again BP rise was observed. So we added dexmedetomidine infusion 25 mics per hour for her. After that, she was quite stable overnight. We planned extubation next day in the morning. So we will stop all this infusion, and weaning was started gradually. Volume AC to SIMV, then CPAP, then TPs. After extubation, patient was awake and alert, maintaining saturation also. So patient was shifted to ward next day in the morning and eventually discharged from the hospital on post-op day 7. For extubation, we should give adequate time for weaning. Extubation should be done by experienced anesthesiologist in semi-upright or sitting position, and post-extubation close monitoring needed in this patient. Then as an anesthetist, why we should worry about this morbid obese cases? So they are extremely diminished oxygen reserve because of the diaphragm pushes upward and decrease in FRC, decrease in expiratory reserve volume, and eventually decrease in total lung capacities. They are more prone to hypoxemia than normal patients, and because of obesity, hypoventilation syndrome, and hypercarbia, they are very sensitive to sedatives, and difficult intubation and crucial extubation observed in this patient, and they are very difficult to ambulate. So extra human resources were needed in this patient. For regional anesthesia also, they are very difficult to position. Sitting position always comfortable than lateral for us. Then difficult to identify the midline, palpate the spinous processes, requires longer spinal needles than standard. There are, because of fat deposition, the increased chances of wet depth during the epidural placement. So in these cases, USG may be helpful to identify the subintrathecal or epidural space. And because of epidural fat deposition, they require 20 to 25% less of local anesthetics as compared to normal patient. Again, this because of this fat deposition around the pharynx, lateral pharyngeal wall, back of the neck, they are very difficult for external manipulation. Obviously, difficult laryngoscopy, giving cricoid pressure because of short neck, and even we could not ventilate or intubate patient. The front of neck axis like cricothyrotomy or tracheostomy will be difficult in this patient. So coming to pathophysiology, obesity, obviously there is more calorie intake and less expenditure. So positive calorie balance stored as a fat in adipocytes as a triglyceride. There is increase in adipocytes which releases pro-inflammatory cytokinins like interleukin 1, 6, TNF alpha, which stiffens arteries in this patient and also impair the glucose metabolism. Over the period of time, they develop insulin resistance. Insulin has a property of anti-inflammatory, but because of insulin resistance, it diminishes the anti-inflammatory property of insulin in these patients. And because of increase in the BMR, the increased oxidative stress is observed. So all this lead to state of inflammatory state in obesity. Because of insulin resistance, pancreas tends to secrete more and more insulin in the circulation, which stimulate the sympathetic nervous system, which increases the norepinephrine in this circulation, which is vasopressor. So it increases the systemic hypertension or develops systemic hypertension in this patient over the time. Insulin also stimulates adipocytes, which release angiotensinogen in the circulation, which activates renin-angiotensin-aldosterone system in the kidney, which lead to sodium absorption and hypervolemia was observed. So this leads systemic hypertension, hypervolemia, increased blood flow to the adipose tissue, which lead to load on the left ventricle. So there is left atrial enlargement, left ventricular, eventually hypertrophy was observed. And because of hypertrophy, the impaired relaxation was there. So diastolic dysfunction is observed in this patient, which lead to left heart failure. And because of left heart failure, back pressure generates, which lead to pulmonary hypertension, and eventually right ventricle atrium also involved. Heart tissue infiltrated by the fat cell, there will be conduction abnormality because of pressure-induced myocyte degeneration. So they are very prone to arrhythmias. This abnormal activity of lipoprotein lipase will lead to metabolic disturbances in this patient. So what are the various diseases linked to obesity which we have to keep in mind? CVS, as I already told, coronary artery disease, hypertension, atherosclerosis, hypercoagulous state, and sudden death can also observe in this patient. In respiratory system, there is restrictive lung disease, sleep apnea, asthma, pulmonary embolism, pulmonary hypertension, obesity, hypoventilation syndrome was observed. So we can, in elective cases, we can advise PFTs, polysomnography in this patient. Endocrine metabolic syndrome was observed, diabetes, hypothyroidism, gout. So we have to evaluate all these comorbidities. And in liver, fatty liver was observed, cholelithiasis. In GI tract, hiatus hernia, they are more prone to gastroesophageal reflux disease. Delayed gastric emptying was there. Mass ventilation, because of air insufficiency in the stomach, there are chances of aspiration also. Because of immobility, varicose vein and DVT was observed in this patient. They are more prone to fractures because of osteoporosis, osteoarthritis, backaches, musculoskeletal connective tissue is also impaired. So hernias can observed in this patient, and carpal tunnel syndrome, which is most common. And oncologically also, CA endometrium, CA breast, CA colon, and prostate and also. So obesity is always linked to metabolic syndrome. How we as anesthetists, we should know the outcome of this patient. So we have to keep all this in mind. Like metabolic syndrome, how we diagnose, following criteria. If 3 or more are present, then we can diagnose the metabolic syndrome, like abdominal obesity, triglycerides more than or equal to 150 milligram per dl, HDL in men less than 40 and in female less than 50 milligram per dl, BP if more than 130 by 85 millimeter of mercury, and fasting blood sugar more than 110 millimeter of mercury. Obesity always, patients have obstructive sleep apnea. So long term of consequences of obstructive sleep apnea which lead to obesity hypoventilation syndrome, which is also termed as Pickwickian syndrome, which is characterized by BMI of more than 50 kg per meter square. There will be alveolar hypoventilation in this patient, which can lead to hypoxia and hypercarbia. Heavy nighttime snoring was observed in this patient. Because of hypoxemia, there will be secondary polycythemia. And because of this circulatory overload, there will be right and left ventricular hypertrophy, as I'll discuss earlier. Eventually, it can lead to right heart failure or pulmonary hypertension. Bedside, we can do one thing. We can assess obstructive sleep apnea. What is obstructive sleep apnea? Cessation of airflow more than 10 seconds. If it happens more than 5 times per hour, or 30 times a night, it is significant. This stop bang, each word stands for something, like S for snoring, T for tiredness, O for obstructive breathing, P for hypertension, B for BMI more than 35, H of more than 50, neck circumference of more than 40 centimeter, and male gender. If patient positive for at least 2 questions also, then we can interpret as a low risk. Of 3 to 4, then intermediate risk, and for 5 to 8 questions, we can grade him as a high risk for obesity hypoventilation syndrome. So we can predict the risk of post-operative outcome. Because of difficult mass ventilation will be there if 2 or more present. This following 5 criteria can say that it is anticipated difficult mass ventilation. Like B stands for beard, O stands for obesity with BMI of more than 26, edentulous, elderly, snoring was present. We did this emergency case, but if patient came for elective cases, so we have to advise this pre-operative advices we should give for this patient, like psychological evaluation, nutritional evaluation, weight loss before surgery, then pre-op spirometry for at least 7 days pre-operatively to reduce the risk of post-op complication. And sometimes patient patient with obesity hypoventilation syndrome will require CPAP perioperatively in the pre-op and post-op period. Deep breathing exercise we can advise to increase the lung capacity of this patient. Pre-op nebulization, if patient is a smoker, then we have to advise cessation of smoking for 6 weeks. Evaluation and optimization of comorbidities like diabetes, hypertension, and hypothyroidism. Morbidly obese patients, they are very prone to hypoxemia and hypoxia. So how we can tackle this hypoxia situation? We can give apneic oxygenation. What is apneic oxygenation? Is high flow of oxygen given at a high concentration through HFNO or Thrive, buccal oxygenation or CPAP or nasal cannula also. What it does, it fills the dead space, the pharynx, larynx and alveoli and increase the alveolar oxygen store. So what it does, it increases the safe apnea period in this patient. So normally in normal patients, we observe safe apnea period without these techniques like for 8 to 10 minutes. But as these obese patients are very prone to hypoxia, they're extremely short safe apnea period, like 2 to 3 minutes also. So through these techniques, we can increase this safe apnea period. Safe apnea period is the time between muscle paralysis and apnea until the saturation drops to potentially dangerous levels. For maintenance of anesthesia, we have to calculate the drug dosing according to ideal body weight to prevent under or overdosing of the drugs. Highly lipophilic drugs like propofol, succinylcholine, we can give as a total body weight for induction, and maintenance we can give as the ideal body weight. Opioids according to lean body mass. Less lipophilic drugs like non-depolarizing muscle relaxants we can give according to ideal body weight. How we calculate ideal body weight? It is height in centimeter minus 100 in male and height in centimeter minus 105 in females. And lean body mass is ideal body weight plus 20% of total body weight. So pain management is extremely important in morbidly obese patient. We can give multimodal analgesia instead of opioids to decrease the consumption of opioids. Drug like paracetamol, NSAIDs, acetaminophen, and dexmedetomidine can be given. All these can combine with local infiltration or nerve blocks. Type blocks can be given in the bariatric or abdominal surgeries also. What are the special challenges for anesthetists in obese patient? Venous access is extremely difficult for this patient, so we need USG also sometimes for venous access, arterial access, central venous access. Airway management and ventilation detailed evaluation planning is essential, including the fiber optic bronchoscope also. So we should keep in mind plan A, plan B, plan C for this intubation criteria. For hypoxemia, desaturation, we can give apneic oxygenation. Always the possibility of risk of aspiration as there is a decreased gastric emptying, so we should keep in mind. Then positioning is very important to aid our intubation. So ramp position given the pillows. Monitoring is also extremely challenging. We have to arrange for large PP cups. ECG tracing sometimes difficult because of fat deposition in the anterior of the chest. So there will be low voltage ECG tracing can be there. Drugs dosing should be calculated according to ideal body weight. Avoid rapid filling crystalloids, colloids in this patient. And pain control is must to improve the post-operative outcome of this patient. Already they have reduced lung capacity, so because of pain, this can worsen. So multimodal analgesia should be kept in mind. Careful use of opioids in this patient. It is the take-home message. Conduct of anesthesia can pose a formidable challenge to the anesthesiologist and intensive care staff. We should require well-equipped hospital with the well-trained staff for these patients. Access to critical care facilities should be there, and specialized interventional diagnostic, transport and operating room equipment should be there. Better understanding the pathophysiology and complications can accompany obesity may improve their care and outcome post-operative. Thank you.